So, hello everybody. Before I begin, I want to thank Dr. Georgopoulos, Dr. Kosmas. So, I'm going to present also an interesting case from our practice at Onassis Hospital. The case is about an 80-year-old female that was examined at the outpatient department, reporting a typical chest pain with gradual worsening. From her past medical history, we have arterial hypertension and osteoporosis with a baseline of creatinine 0.8 and a calculated creatinine clearance around 50 ml per minute. Her medication history includes aspirin, a low-dose statin, and amlodipine. We can see the logistic Euroscore, the Euroscore 2, and the high surgical risk score. From her diagnostic coronary angiography, we didn't have any significant coronary stenosis, whereas at the screening echo, we have a left ventricular ejection fraction around 60% with an AV of 0.7 and an AOV max indicating severe aortic stenosis. We have some videos from the screening coro, as you can see, which demonstrate the patent vessels. And here we can appreciate the severe aortic stenosis with an IVV max of 4.15 and the elevated pressure gradients, the well-functioning hypertrophic left ventricle. Also some more videos here. We can appreciate also the severe mitral regurgitation from which the patient is suffering from. So pre-procedural CT angio shows suitable transfemoral access despite moderate calcification as well as adequate coronary osteo heights. The main anatomical considerations are Sievert's type 0 bicuspid aortic valve and significant tortuosity of the left common iliac artery. Here the CT images demonstrate the burden of the valvular calcification with a calcified raphe between the left and non-coronary cusp. The 42-degree angulation is also highlighted along with the marked tortuosity of the iliofemoral vessels. Again, we can appreciate here the extreme tortuosity of the left common iliac artery and the promising femoral access from both sides. Our valve choice is an Evolut 26mm valve. So the heart valve team of our hospital decided that transcatheter aortic valve implantation is the optimal strategy for this specific patient. And our access was obtained via the right radial and right femoral arteries under ultrasound guidance. The valve was introduced through the right femoral, and the Safari small stiff wire was positioned, and pre-dilatation was performed with a 20x40 Osipka balloon. I'm going to show you now the valve deployment and the subsequent complication that occurred. So the initial aortic root angio is shown with a pigtail catheter positioned in the aortic root. Mild aortic regurgitation can be appreciated. And on the right side, on the right side we have a prominent calcific nodule that's visible as a dense radiopaque focus. And the next step, the native aortic valve is crossed using an AL catheter and a straight guide wire. And after positioning the catheter in the left ventricle, the system is exchanged for a Safari small stiff guide wire. And we then proceed with the balloon aortic valvuloplasty using a 20x40 Osipka balloon. We can see clearly the balloon opening, the balloon dilation demonstration. So the delivery system is furthermore advanced over the Safari small stiff guide wire and crossed through the native aortic valve. We then perform an initial angiographic acquisition to evaluate the first positioning of the valve. So we then begin deployment of the transcatheter valve, and following a number of attempts, as we can appreciate on the right side, the valve is finally released. I'm going to move it a little bit for better time management. So as the nose cone is being retracted, the transcatheter valve becomes displaced and migrates into the ascending aorta. At the left, we can appreciate the initial migration position of the valve. A snare was advanced via the LFA to capture and reposition the migrated prosthesis towards the aortic arch. In parallel, given the development of severe aortic regurgitation, urgent advancement of a second transcatheter valve was performed. And here we can see the deployment of the second transcatheter valve with a very satisfactory angiographic result. And finally, an attempt was made to secure the migrated valve in a more stable position within the aortic arch, without obstructing or compromising the supraaortic branches. At the right side, we can see the final angiographic result. So we can see very quickly the echo that was performed post-TAVI, with the estimation of the velocity in the aortic valve around 1.5 meter per second, the good positioning of the valve, some more short videos that I'm going to go by very quickly. Still, we can appreciate the MR that's there. So post-TAVI, the patient was admitted to the ICU, intubated under propofol, and supported with low-dose noradrenaline. Due to a drop in hematocrit and hemodynamic instability, the CT angio and surgical assessment were performed. Here we can see the CT angio that was performed immediately post-op, and we can see a clear dissection that originates from the end of the aortic arch and goes down till the right common iliac artery. Some more images that demonstrate the series dissection and the 3D reconstruction on the right side from our program. Also another one that shows clearly the dissection. So evaluation after assessment by cardiac and vascular surgery teams, conservative management was chosen as the patient remained stable. The valve was functioning properly, and surgical intervention was considered a very high risk. So the patient gradually improved hemodynamically, was successfully extubated, and remained neurologically intact with a Glasgow Coma scale of 15 out of 15. Her hospital course was complicated by complete AV block, necessitating permanent pacemaker implantation. Follow-up, CT angio 1 week later, didn't show any actual changes. This is the CT angio performed 6 months after the operation. We can still see the big aneurysm that goes again down. And here we can see the follow-up echo, which is very satisfying considering the aortic valve implantation. And some considerations about aortic dissection and TAVI. Aortic dissection is a rare but potentially fatal complication of TAVI that occurs in less than 0.5% of all procedures done. Results from guide wire catheter manipulation, balloon valvuloplasty, valve deployment, or trauma to heavily calcified aorta are the main mechanisms of this. Prompt recognition using angio, transesophageal echo, or CT is very essential. And very good pre-procedural planning is essential in order to minimize the possible complications in these cases. Thank you very much.
Dr. Dardas?
Good save, but I wanted to ask, why do you think this happened? Why do you think that? I think the problem was the nose cone that was entrapped. Why did this happen, and how could this be avoided?
We have to consider the bicuspid anatomy and the severe calcification of the aortic valve in this specific case, and as a possible mechanism, I mean of impaired valve anchoring in the ascending aorta.
But also the question why this happened, I would also ask the same question for the dissection, because what it's hypothetical, but it can't be facilitated the repositioning of a snare via snare or through a second snare. So I think the pullback with the snare was in the inner curvature of the aortic arch, and having a second one on the outer curvature, bringing the valve a little more parallel to the aortic root would facilitate a more smooth drift to the descending aorta. So this could be also an issue regarding the dissection. Nevertheless, was a great save, and the aortic type B dissection does not make any problems if you don't have any malperfusion in that case.
Well, I might speculate two answers to this question. The first one is the valve was underexpanded clearly, so there was also we lost position of the valve of the wire a little bit because we needed to retract it in order not to have a pop out, but initially, so of course we had. So in retrospect, maybe in this situation, it would be better to use not a Confida or a Safari, but maybe a Landerquist would be a good.
That's right. For bicuspids, I think Landerquist is the solution.
Yes, sometimes we avoid, but we should always remember. And the other thing, why did that happen? So we didn't have time. Patient was really. This was not good. We tried, of course, the better option is to have two snares, otherwise the valve can make a turn, but it was not stable. It was coming up and down, and we tried to stabilize a little bit and then retract. But while trying to retract it, and of course, if you see the tortuosity of the aortic arch and also the discrepancy before and after the carotid. So I think this was the issue there.
Of course, it was really great that you pulled the valve and did the second and implanted the second valve to resolve the immediate problem that was key for the success of this story. It was really it's a great case. Thanks.
So thank you.
May I suggest that because it happened to us as well once, and we couldn't get the nose cone out. First of all, you need to be very, very gentle and do very slow motion if you predict that there is a lot of calcium, the valve is underexpanded. And if you see that the valve is coming gradually, is moving, then the better solution is to put a snare and snare the cone. And this is how we solve this problem, but it can happen. But the snare inside the LV and snare the cone is one solution.
I think you're right, and it's an idea. But I think in the meantime, we should be very meticulous in pre-dilatation of the valve. Maybe if you have used a true balloon or a non-compliant balloon, maybe do more proper dilatation, we would have avoided the whole thing altogether. So thank you, and may I